Bienvenue à l'Assemblée haïtienne de Orthopédie et Traumatologie 2022. Je suis très heureux de vous accueillir à cette réunion virtuelle. On m'a demandé de prononcer le discours d'ouverture de cette réunion. La dernière fois que j'ai prononcé un discours comme celui-ci, en 2021, il y a eu un terrible tremblement de terre juste après. Alors, j'espère que je n'ai pas porté malheur à Haïti. C'était une terrible tragédie, mais ce tremblement de terre a aussi été l'occasion pour Haïti de démontrer à quel point la chirurgie orthopédique s'est améliorée pendant 11 ans. Depuis le tremblement de terre de 2010. Je suis très fier de mes collègues haïtiens pour leurs soins experts et de ces blessures l'année passée. J'ai pu visiter pendant la catastrophe et j'ai pu voir la qualité des soins qui ont été dispensés. Chaque malade avait un plan approprié pour ses blessures et chaque plan a été exécuté avec expertise. De nombreux facteurs ont contribué à ce succès. Avant tout, la compétence et le dévouement des médecins et des infirmières qui ont travaillé jour et nuit pour protéger des grands soins, mais aussi l'équipe internationale d'amis et des collègues qui a envoyé du matériel et donné des conseils. De plus, leur réponse de 2021 a montré à quel point la communauté des chirurgiens orthopédistes en Haïti est devenue forte. Des conférences comme celle-ci ont contribué à renforcer la force de cette communauté. Il s'agit de la 9e réunion annuelle du HAAOT. Au cours des 3 dernières années, à cause du coronavirus, nous avons tenu la conférence virtuellement à cause de la difficulté de se rendre en Haïti. Nous avons hâte de nous revoir dès que nous le pourrons. Mais la philosophie de base n'a jamais changé. Chaque année, nous construisons les thèmes de la conférence autour des choix de nos participants à la conférence. Le programme est une combinaison des conférences invitées d'experts étrangers et d'experts locaux et de présentations par des résidents. Le programme de cette année reflète cette philosophie. Nous sommes fiers de vous offrir une belle horaire avec une variété d'excellents conférenciers. Je tiens à remercier l'équipe de UCSF ainsi que le Dr. Swankowski pour avoir rendu belle la qualité de la science orthopédique en Haïti. Personnellement, l'aspect de cette conférence dont je suis le plus fier est la façon dont elle a contribué à construire une communauté des jeunes qui se consacrent à la chirurgie orthopédique. C'est aussi vrai pour mes jeunes collègues américains que pour les jeunes chirurgiens orthopédistes d'Haïti. J'ai vu certains de ces jeunes passer du statut d'étudiants en médecine et de résidents à la fin de leur formation pour devenir des chefs. Je tiens à remercier les organisateurs de cette année, Jameson Omar, Shravia Kakalomari et André Augustin, pour avoir si bien perpétué cette tradition. Bienvenue.
Merci, Dr. Dyer. Mark? Donc, pour faire suite au docteur Dayan, et bonsoir et bienvenue à tous. Donc, 1 an plus tard, nous sommes ravis de vous revoir dans le cadre de notre conférence annuelle, HAOT 2022. Les conditions n'allaient pas dans notre sens, encore une fois, mais grâce au travail de l'équipe organisatrice et de vous, la communauté orthopédique haïtienne et nos amis d'étrangers, nous pourrons discuter, partager et apprendre de notre passion commune, l'orthopédie et la traumatologie. Et cette année encore, nous avons essayé de diversifier les sujets avec une emphase particulière sur la recherche en Haïti par les Haïtiens. Et pour continuer dans ce mouvement, bien entendu, on va passer la parole au docteur Augustin, et résident finissant à l'HUP, qui va prononcer quelques mots également. Merci.
Merci, Marc. Bonjour à tous. Et je commence par dire que Denis Diderot eut à dire à propos de la science qu'il y a 3 moyens principaux d'investigation. Premièrement, l'observation, deuxièmement, la réflexion et troisièmement, l'expérimentation. L'observation recueille les faits, la réflexion les combine et l'expérimentation vérifie les résultats de la combinaison. Nous avons toujours eu les 2 premiers, à savoir l'observation ainsi que la réflexion. Cependant, dans notre contexte, bien que négligée, l'expérimentation s'avère aussi difficile. La science n'a pas de barrière, elle est universelle et se renouvelle constamment. En effet, il est grand temps pour nous, Haïtiens, de mettre sur papier ces multiples observations et expériences certainement enrichissantes afin de les partager avec toute la communauté scientifique nationale et internationale. C'est justement l'orientation que nous avons donnée à la conférence annuelle d'orthopédie et de traumatologie haïtienne de 2022. Nous remercions d'entrée de jeu du fond du cœur nos sponsors et organisateurs qui, malgré notre situation difficile et chaotique, ont rendu possible la réalisation de la conférence de cette année. Nous vous en sommes très, très reconnaissants. Bienvenue à tous encore. Je vous souhaite une bonne participation. Merci.
Thank you all for your words. And I just want to say on behalf of the organizing community, we're so happy to see all you here today. As we've done with previous year's conferences, all of this information will be recorded and posted on our YouTube page. So hopefully you'll be able to go back and view it there as well. But to get started, we have a 4-part series on research methodology produced by Dr. David Shearer and Dr. Sam Morshed from UCSF. Some of you may have met them. They have attended a similar conference in HAOT in past in Haiti. And they will be joining us later after their presentations to answer any questions that we have. So without further ado, I will go ahead and start the presentations. We will have 2 presentations and then a question and answer session followed by the second 2 presentations.
Good evening. Thank you for the opportunity to be part of the Haitian Annual Assembly of Orthopedic and Trauma. My name is David Shearer, and I work at UCSF, the Institute for Global Orthopaedics and Traumatology. This is going to be actually a short series of talks delivered by myself and Dr. Sam Morshed, my partner. And we'll be talking about some fundamentals of research methodology, and we're going to use this conceptual framework. What we're going to try to do in this series of talks is walk through going from an idea, could be any idea, a clinical question that you have in your everyday practice, and taking that idea and turning it into a research question or a testable hypothesis. Once you have that testable hypothesis, we'll try to help give you some guidance on how to go from that research question into a full research proposal. And from there, the final step is taking that proposal and implementing it into a research protocol, something that you could actually implement in some of the more nuts and bolts of doing clinical research. So this first talk is about taking a clinical idea and turning it into a question. And I would argue that this is the most important of all of these talks, because all the fancy statistics and study designs and things in the world cannot compensate for a bad research question. So this is really, I think, probably where you should spend the most time in a research study, is just picking the right question from the very beginning. And the learning objectives for this talk will be, it'll be a two-step process. So the first step is taking the clinical question and refining it into a testable hypothesis. And we can do that using a simple acronym known as the PICO method, P-I-C-O. And then the second stage of it is, once we've gone through PICO, we'll talk about how we can decide whether a question is worth asking. You know, are we willing to really commit the resources? And we'll do this using a framework known as FINER. And, you know, it's often said that ideas are cheap. It's easy to come up with clinical questions. I'm constantly in the operating room asking, what's better, this or another thing? You know, it happens multiple times in a case, but it's not feasible. Although we could design a research question around any one of those dilemmas that arise in our everyday clinical practice, only some of them are going to be feasible for us to actually do a research study on. And so hopefully with these two methods, we can help with deciding which one of these we really want to pursue. So we'll begin with this example, and we'll use this example throughout this series of talks. And this example starts with a clinical problem that I think is common throughout the world. And that's that open tibia fractures have a high rate of infection, and there's uncertainty about whether we should use internal or external fixation. So at this point, it's just a problem, but how can we take this and turn it into a testable hypothesis? This is the research question I would argue that we're shooting for. In adults with open tibial shaft fractures, is there a difference in the rate of reoperation for deep infection comparing statically locked intramedullary nailing and uniplanar external fixation? You can see how much detail is embedded in this. There's a lot of information in this one research question that's really going to guide all the subsequent steps of developing a proposal, coming up with eligibility criteria, all the things subsequent talks. So how do they go from this problem statement to a real defined research question? So PICO is a nice framework for doing that. PICO stands for population, intervention, comparison, and outcome. It's a very simple framework, but it's an exercise that I still go through every time I'm thinking about a new research question. The population is pretty self-explanatory. It's who will be included in the study. And ideally, you'd be as specific as possible. Some examples of things that might be helpful for this in trauma studies would be things like age, the anatomic location, or maybe characteristics of the injury. Not all injuries are created the same, so we might incorporate some element of injury severity, whether it's an open or closed fracture, things like that could all be key aspects of our population. The I and the C are intervention and comparator, and this is the treatment that we want to test, that we're interested in. And typically, the intervention is the thing that's kind of new or investigational is our intervention. In this case, we're going to be looking at a statically locked sign nail. And then the comparator is what's kind of the current standard of care, which depending on the setting might be a uniplanar external fixator. The outcomes are what you will use to compare the intervention and the comparator. And there are a variety of different outcomes that you can choose from. We'll talk about that a little bit more in the proposal development phase, but it could range anything from clinical endpoints to X-ray outcomes to cost. The key thing when it comes to developing your question is that you really have to design your study around one primary outcome. And that's what your power analysis and all those things will be based on. So coming back to our research questions, so our population we've stated, we could say, well, we're not interested in kids. We don't want to look at closed fractures, and we want to focus on the tibial shaft rather than getting into pilons and plateaus. So our population could be adults with open tibia shaft fractures, OTA type 42. Our intervention, as I mentioned, is going to be statically locked intramedullary nailing, and we're going to compare that to a uniplanar external fixator. We're not looking at ring fixators or something like that. And our outcome is going to be reoperation specifically for deep infection, because we're really concerned about this infection question. So how do we take that outline of PICO and convert it into a question? Well, almost no matter what you said for the PICO, you can just sort of plug it into this and say, in the population, is there a difference in outcome comparing the intervention to the comparator? So here's the example: in adults with open tibial shaft fractures, is there a difference in reoperation comparing intramedullary nailing and external fixation? You can read that, but you can see how you can just take the answers in your PICO and just plug it right into a research question. So that's the first step. So now we have taken our clinical question, and now we have a refined, testable hypothesis in our more refined research question. So the next step is we're going to want to think about what kind of study design we would use to answer this question. And I'm not going to go through this in great detail because Dr. Morshed is going to have another talk on controlling bias, and he's going to go into each of these study designs in more depth. So I'm just going to give you the quick and dirty here, which is that there's a pyramid of evidence. At the highest level are randomized trials, and at the bottom, level 5 evidence is just expert opinion. And as we go lower down on the pyramid, there tends to be more and more bias and lower quality of research. But on the other hand, the resources also get higher as you go further up. So there's a trade-off essentially between the resources required to perform a study and its ability to answer that question without bias. And as we go into the next phase of thinking about whether our trial is feasible or not, sometimes we may start thinking that at the highest level of the pyramid and having to move down the pyramid a little bit in order to make our study more feasible. And this is a careful balance that you have to go through as you're going through this next step of the process, which is called FINER. It's an acronym to help us decide whether our project is feasible. And this isn't necessarily something where you go through it one time and you decide, nope, it's not worth it. It might be that you go through it once with one idea in mind of how your study might go, and you find that it's not feasible, and then you go back, you make some changes to your study design or changes to the research question or outcomes that you want to look at, and you make it more feasible, and it becomes a question that's worth asking. So just bear that in mind as you're going through this. This is not a one-shot deal. You may go through multiple iterations of your project before you're ready to take it on to the next step. So what does FINER stand for? Let's jump into this. So what is the acronym? So it's feasible, interesting, novel, ethical, and relevant. What does each of these mean? Well, the F is for feasible, and feasibility is probably the number one thing that shoots down a research idea. And there are a number of things that go into feasibility and whether a project is realistic to complete. One of the biggest things is sample size. And if you're going to try to do it all, a study, looking at infection rates at your center and you don't see a lot of infections, then it's just simply not going to be feasible to answer that with a randomized trial. But sometimes by changing your research design, maybe you involve other centers, maybe you change your outcome to something that's a little bit more common, or a study population is something more common, that might change. The bottom line is you need to have the sample size for it to be feasible. Time is a big aspect of feasibility. Do you actually have time to collect the data or the time to conduct the study? If you don't, do you have the funding to hire somebody to help you? If the answer to both of those is no, then it may not be feasible to do, a prospective, study that involves a lot of data collection. But doesn't mean you can't do it. It just means you may have to modulate your study design a little bit. But feasibility is one of the most important things, and it's important to really put a lot of thought into this before you embark on a project. Interesting is pretty self-explanatory. If you're going to be spending, sometimes these projects can take years to complete. And if for you to get through all that, it needs to be interesting to you. And it also, you would hope, would be interesting to others at the end. You don't want to pick something that's not going to sustain your interest over the full course of completing the project. N is for novel, which means, has this study been done before? And every time I come up with a new research idea, the first thing I do is I go to PubMed and I do a big search and I see what else is out there. And sometimes you find that, somebody's already done, a really good study that already answers your question. And then it's really not necessary to do it again. But other times, there's a real need for it, or maybe hasn't been done in your setting, and maybe it's not generalizable to where you are. And so there are other ways that it can be novel, but this is an important starting point. Ethics is critical and can't be emphasized enough. Not all research questions are ethical, and this can depend on study design. A classic example would be looking at delays in treatment. So you might be really interested in whether delay matters, but it's not ethical to randomize patients to a delay. You couldn't do a randomized trial looking at early versus delayed treatment, because who would want to have a coin flip for whether their surgery is timely or not? But that's something sometimes it can be addressed simply by changing it to an observational study, recognizing that that may add bias. Ethics is going to be the priority. And then the last is relevance. Will your research project in some way change clinical practice or influence policy in some way? And this is, one of the most important things. You've got to make sure that you don't want to just be doing a project to get yourself a publication or something like that. There should be in some way that it may ultimately change the way patients are treated, or at least the way decision makers approach a problem. So I think this is really important. Once you've gone through this and you have your research question, then you just have to ask yourself, based on all that, is it worth, answering this question? And are you willing to commit the resources? The number one of which is going to be your own personal time and effort. Hopefully, after you've gone through this process and iterated a little bit, the answer to this will be yes, and you can move on to the next steps that we'll talk about in taking your project and developing it into a more formal proposal. So the take-home points from this talk are to remember that developing a good research question involves the PICO method: population, intervention, comparator, and outcome. And then once you have that good testable hypothesis, you can use the finer method: feasible, interesting, novel, ethical, and relevant, to help you decide whether you want to pursue addressing that question. Thank you.
So we'll have one more presentation from Dr. Shearer.
Okay, for the next talk, we're going to be discussing the preparation of a research protocol. So coming back to our conceptual framework here, we now have our clinical question or clinical idea that struck us in the operating room. We've now turned it into a robust and testable research question. And now we're going to be taking that research question and actually adding on some of the more important details that are actually going to go into a proposal. And that could be a proposal to the IRB, proposal for funding, really just taking things towards the next step of actually conducting your study. So the learning objectives here are to just define a few terms that are really critical for a proposal. Eligibility criteria, we'll talk a bit more depth about outcomes, and then we'll go into weeds a little bit on sample size calculation, because it's often a big stumbling block. And then we're going to discuss something a bit about the ethics of research and the importance of conducting of responsible conduct of research. So we're going to continue along with the same example that we have been using, which is this randomized trial comparing intramedullary nailing and external fixation for open tibia fractures. So the kind of first bit of detail that we're going to want to add on for a research proposal is to further specify our study population, and that's done using eligibility criteria. And this is what will be used during a study to screen patients who may be eligible and determine who can be included and who should be excluded. So it's sort of a checklist, but it really specifies who the target population in the study will be. And I think a lot of times there's a temptation to really try to add lots and lots of these inclusion and exclusion criteria to create this really homogeneous population, which from an experimental perspective is a good thing to have a lot of homogeneity. But it has some downsides as well. You know, if you go too homogeneous, then first of all, you may compromise a lot of your sample size and make it hard to conduct the study. We'll talk about that more in a second. The other downside of if you is that you lose the ability to generalize your results to, you know, more broad population. So if you make it all about, you know, left-sided, you know, proximal 1/3 open tibia shaft fractures with wounds that are, you know, between 5 and 8 centimeters. I mean, you'll have a very specific population, but you won't be able to generalize your results and you'll have a hard time finding those patients. So that's kind of the key thing. That's the argument to avoid being too restrictive with your sample size. On the other end of the spectrum, if you do go too broad with your eligibility, you may end up with a situation where you have patients in your study who respond differently to your intervention in your control. So maybe open and closed fractures might have very different, you know, responses to your intervention in your control. And if you lump them all together, you may find that it washes out the effect that you're interested in. So you kind of have to find the balance here of this target population that's appropriately specific to address your research question, but still have adequate sample size and the right degree of homogeneity to see the effect from your intervention that you're interested in. Just coming to our example, in this case, we've specified our inclusion criteria, our OTA type 42 tibia fractures. We're going to focus on the shaft fractures because, you know, getting into, you know, tibial plateau fractures and pilon fractures might behave very differently. The treatments are very different. We can't really use nails in all cases and things like that. We're going to specify that it's Castilla type 1 to 3A because, you know, the injuries requiring flaps. There are a lot of other issues there that, you know, they may behave very differently, have much higher rates of infection independent of anything that has to do with our fixation, similar with vascular injuries or other things. And then kids have very different response to treatment than adults. They heal fractures differently. So we're going to specify adult patients for inclusion criteria. So this is kind of the initial first pass of patients that we think could be eligible to be in our study. And then we're going to apply our exclusion criteria. So these are the things that once we've identified those patients, we're going to gather some additional information and use these criteria to exclude some of them who might not be good for our study. So one example might be patients who present very delayed. In this case, we chose 24 hours, but it could be a bigger delay. The concern being that if somebody's so delayed and has a very contaminated fracture, we may not want to put a nail in those patients. We already talked about the issues about flap coverage and vascular injury, and other issues that might come up would be things like patients with severe head injury may not be able to participate in some of your outcome assessments and things like that. You might exclude patients who have certain risk factors that may prevent them from following up. Things like that also might influence the mechanics of the study. Could be things that you want to keep as exclusion criteria. Now that you have eligibility criteria, we can talk a bit more about outcomes. So as we've mentioned, you can only really have one primary outcome because you have to power your study around something. You can only pick one study or one thing to power the study around. But you might want to have additional outcomes that you measure because sometimes the primary outcome, it might be the most important outcome, but it may not. You may want to have some additional outcomes that help explain the mechanism behind the primary outcome. For example, if the primary outcome is quality of life, and you find a difference in quality of life between the two treatments, you ask why. Is it because they have a higher infection rate? Is it because they're healing less quickly? What's driving that difference in the primary outcome? And so that's where secondary outcomes become very important. But you can't make as strong a conclusions about the difference between the two interventions with secondary outcomes that you can using the primary outcome because it's not powered for those differences. The other thing that's important about outcomes that we haven't talked about is timing. So, and timing could be both the duration of time or time point that you're going to assess the outcome. And sometimes you might assess it at multiple time points. So, and you want to specify what that interval is. And this is going to depend on what the outcome is. So for example, if your outcome is, infection or let's say even length of stay, then it's going to be a very short period of follow-up that's required. But if you're interested in post-traumatic arthritis because you're worried these tibias are getting malunions, that may take decades of follow-up to detect. So it might be very interesting to look at that, but that may or may not be feasible. So the timing of the outcome is also very important and may ultimately influence feasibility as well. This is, I think, a nice conceptual framework that I use when thinking about outcomes. Basically, the idea here is that whatever clinical problem, injury, or disease that we're looking at, there's some, underlying biology that's pathologic. That pathology leads to some symptoms that the patient experiences that may or may not influence their function, which may or may not influence their perception of their health, which may ultimately influence their overall quality of life. And so we can measure outcomes anywhere along this spectrum. If we measure close to the left side at the, the root cause sort of problem, it's easier to detect differences. But it's very often the case that those differences we see at that level may not translate to an actual difference in quality of life. So if we come to our example of the open tibia study, an example of sort of a biologic variable would be measuring X-ray healing. It could be X-ray healing or X-ray alignment. For healing, it could be the Russ score, and that's getting at the root of, is the bone healing? But we've all seen cases where the bone either didn't heal or healed slowly, and the patient doesn't necessarily always have symptoms. So we might go one step closer and measure pain or pain scores, and that's getting us a little bit closer towards quality of life. For function, we could ask if they could do a squat and smile. There's a number of other functional tests we could ask, or what their walking tolerance is. For quality of life, we can look at, there's a number of quality of life scores out there. The EQ5D is a simple one that we often use that measures a patient's health-related quality of life. And lastly, we could look at clinical endpoints that matter to patients' quality of life, like having another surgery or a major complication. And the key thing with this is that the thing that we're probably we would all agree is most important is, are we improving the patient's quality of life? But the further we measure on that end of the spectrum, the more sort of noise we might get from different aspects of the patient. What's their pain tolerance? What are their, what's their baseline functional level, as well as their environment? How much help do they have? How much social support do they have? So I think the key thing is to try to measure across this spectrum as much as you can. So choose a primary outcome that's probably closer to the right side of the scale towards quality of life and what really matters to patients, but make sure to measure the secondary outcomes across the spectrum so that you have an understanding of what the mechanism is that's leading to the differences in the more clinically important outcomes for quality of life. So here's an example. So in this study, we're going to look at a primary outcome of reoperation, but there's a number of secondary outcomes that we can look at as well, both radiographic alignment, radiographic healing with the Russ score, and that again is on that biologic end of the spectrum. We can look at a quality of life questionnaire, which is getting further to the other end of the spectrum, and then have a squat and smile, which is kind of in the middle as a functional outcome. Now that we have our outcomes, we can think about power and sample size. And this is, I think, we're going to try to stay away from, getting in the weeds of statistical analysis and bore everybody with statistics. But if there's one kind of statistical concept that it's important to understand, I would say it's this concept of power, which is the probability of finding a difference when one actually exists. I could probably say that 10 times and I still don't totally know that it takes a while for that to wrap your brain around that concept. Perhaps a better way of stating is, what happens if you don't have enough power? Basically what happens if your study is underpowered, meaning the sample size is too small, is that your study will show no difference, even when there's a difference between the two treatments that you're interested in. So it's a source of negative studies, and you don't really want to do it's not ideal to conduct a study that's too small and conclude there's no difference when in fact there actually is a difference between the two treatments. And so we can try to predict that by doing sample size calculations. We can try to anticipate how many patients we would need to see a meaningful difference. So how do we do that? There's a number of inputs that go into it. And it's a little beyond the scope of this to go in too much depth, but you have to know the type of outcome, whether it's a binary outcome like reoperation or a continuous outcome like quality of life. You need to know what difference you're trying to detect. Do you want to detect a little tiny difference, which is going to require lots of patients? Or are you okay detecting a larger difference, which won't require such a large number? You need to know about variability in data. You know about the desired power. So that's sometimes called type 2 error. So that this standard for this is 80%. So you want to have 80% confidence that if you have a negative result, that it's truly negative. And then the alpha, which is the other side of it, which is that if you do find a difference, what's the probability? What's your confidence level that that is true? And, for this outcome in this example, we're going to say that our primary outcome we decided was reoperation. So that's a dichotomous outcome, meaning it's either yes or no. The difference that we're going to try to detect is 20% versus 10%. We'll talk about that a bit more in a second. With binary outcomes, there's no measure of variability. There's no standard deviation that we have to think about, which is nice. The power, as I mentioned, is typically 80%, and the standard for the alpha is 5%. So those inputs, generally speaking, are pretty consistent, regardless of the study. These are kind of the standards. Some people would argue you should have 90% power, but the general minimum is 80%. The general standard for alpha is 5%. So this is kind of a cool resource. You can do the sample size calculation using, all statistical software generally has a package or a command for doing this. But this is a nice free website that UCSF has that you can punch into your browser if you want to do this calculation. It's just samplesize.net. And when you go to this website, you'll see the different types of outcome measures. You just click the link and then you can put all these numbers in there for your particular study. It's going to default give you an alpha of 0.05 and a beta, which is the kind of 1 minus the power. So a 20% beta is equal to an 80% power. And then we can put in our baseline risk, which is 10%, our risk in our two risks, which are 10%, 20%, and then that's going to give us our calculation. And so you see here that with these inputs that I specified here, it would require 400 patients. And on top of that, and to make things even more complicated, you have to anticipate loss to follow-up. So if 20% of the patients aren't going to come back for follow-up, then you actually have to have 500 patients in order to count for that 20% loss and still have 400 patients left. So that also gets factored into your sample size calculation. But this is basically how you do it. And we'll just talk a little bit more about, effect size, because it's probably, of all the variables in there, this is one of the harder parts of the calculation to know what to put in. And it's sort of a tension between two different things. On the one hand, you want the difference you choose to be the smallest effect size that would be sort of clinically meaningful. But you can see that if I look at an effect size of 1%, so if in this case, it would be a reoperation rate of 10% versus 11%. If I thought that was clinically meaningful, then I would need almost 30,000 patients, which is just not feasible. If I say that what's clinically meaningful is 10% versus 15%, then it goes to 1,370 patients. And then at 10%, which I think we would all agree at 10% versus a 20% difference is clinically meaningful, then we need 400 patients. And we're going to say that in our case, that is feasible if you have a busy center. But you have to look at how many patients are you getting, per month, per year, and how long is it going to take you to accrue this number of patients? Can you do it at just your center? Do you need additional patients? So these are all the considerations that kind of go into this sample size discussion. So the kind of key points are that it's based on the primary outcome. In general, more patients is going to be better. and that it's probably the single biggest barrier to studies being feasible. And so you really want to spend a lot of time thinking about this and kind of iterating on your study design to ensure that this is feasible. So now we're going to switch gears a little bit and talk about research ethics. Some may have read about this, others may have not, the Tuskegee syphilis study. This is one of the sort of darkest examples from U.S. history, and arguably research ethics as well. But it's something I think everyone should know about, because I think it's a powerful example of research gone bad. So this was a study, again, it went on over 40 years. The idea took place in a predominantly African-American part of the United States. And they enrolled patients who had a diagnosis of syphilis, and then we're trying to see what the effects of syphilis were over time untreated. They wanted to look at the natural history. And what happened over the course of that period of time, over these decades where the study was going on, is that new treatments came out, like penicillin and other things, that the syphilis became a very treatable disease. But they didn't inform the patients about those treatments. They didn't inform them about the goals of the study. And so, it's really kind of the one of the worst examples of irresponsible conduct of research. And I think it's from the study, a lot of the guidelines and regulations around research ethics have kind of come from this. That's the reason why we have to go through an institutional review board for the vast majority of studies that we do. So I encourage you to read about it if you haven't before. It's very sort of appalling and sad, but also, important history to understand so that we don't, repeat these mistakes. So, just to drive this home, we have to remember that no matter what the study we do, there's almost always some small amount of risk to the participant. Even if it's just a retrospective study with charts, you're still going to be gathering data and patient information, and that does expose them to some risk. When you start talking about interventional studies, like a randomized trial where you're going to change their treatment, then the risk becomes, significant, because the treatment is going to be different based on their participation. And so we really want to make sure that all patients are fully informed and understand the pros and cons of participation, and understand that they do not have to participate, and that if they choose not to participate, that their care will not be any different. That's just, extremely important. IRBs, institutional review boards, are something that we often like to complain about because they slow down our progress and prevent us from starting our studies as quickly as we would want to, but they are really an important resource and protect our patients from, our sometimes overzealous desire to conduct studies and get answers to these questions. And so I would encourage you to consult your IRB, get to know the people that work there, and understand the rationale for why they exist and why their recommendations are in place to protect patients. So just some take-home messages. Remember that your target population is defined by your eligibility criteria, the inclusion and exclusion criteria. You can only really choose one primary outcome, but you can choose secondary outcomes across a spectrum from the root cause of disease all the way up to quality of life. And those can be kind of the way of optimally understanding the effects of your two intervention and comparator. When it comes to sample size, more is better. And remember kind of the issues with effect size and how you want it to be, choose an effect size that's clinically meaningful, but still feasible for you to conduct at your center. And then last, but definitely not least, do no harm, protect patients, conduct research responsibly, and consult your IRB before starting your study. Thank you.
Awesome. Thank you, Dr. Shearer, for those. And we have Dr. Shearer on the call now. So just wanted to open up questions for him as well. So feel free to put them in the chat and we can ask them from there. And then if we have time, we can also open it up as well and allow people to answer or ask their questions over the call. I think Vincent, you had a question as well. Would you like to ask it first?
You want me to do it out loud, or I wrote it on the chat that I can ask it?
How about you ask it out loud to get us started?
Yeah, thank you, Dr. Shearer, for your presentation. I'd like to know about the funding of this, the studies. Which type of studies you would absolutely need funding for, and which type you wouldn't need that, and how do you manage that funding? I mean, how do you decide how to spend it, basically? And my second question is that if you have a good hypothesis, but you know you're not going to have a big enough sample size, would you still do it, or you shouldn't do it, or how do you approach that?
Thanks, Vincent. Those are awesome questions. So funding, yeah, funding is a challenge. I think that in terms of what is the threshold for when you need funding, it's hard to say an absolute rule. I think that if you think about that pyramid of evidence that I kind of alluded to, and I think Dr. Morshed's talks will get more into that, as a general rule of thumb, the higher up that pyramid you are, the more likely you are going to be needing funding. And certainly I think when you get into prospective research, like where you're actually going to be consenting and enrolling patients and then following them over a period of time and having to gather data at various time points, that becomes much more labor intensive beyond what most of us as clinicians could probably do on our own. And so I think that is probably a definite transition point kind of went between sort of the retrospective studies where you're just going to look at data that already exists. There's no particular time frame for how quickly you collect it and do sort of a retrospective analysis of chart data. That can probably be pulled off if you take the time to go through the charts, but it's not time sensitive or anything like that. Once you get into the prospective studies, I think it becomes much more difficult to do without funding. I think in terms of bang for your buck, so to speak, and if you have a small amount of funding, how to spend it. I think that research coordinators are invaluable. People that don't have our busy clinical schedules and in surgery all the time that can help you with that process of consenting and enrolling and gathering data are huge. I think if you're talking about a study design that requires follow-up, that's another big barrier, and using funding to support either cover some of the consultation fees associated with follow-up appointments, x-rays associated with follow-up appointments, or, depending on how much funding you have, covering the costs of the follow-up travel and things like that. And Dr. Morshed is going to talk more about that when he talks about implementation of studies. So, kind of stay tuned for more on that. But I think those are some of the areas that I think, like without astronomical amounts of funding, you can do a really, have a lot higher likelihood of success. I think when you get in a randomized trial that gets, because you're changing patients' treatment, then there becomes this requirement that the onus becomes on you that you have to keep patients safe. And so you really need to be monitoring your data like very closely. You have to have a data safety monitoring board. You have to have people that are, checking the data. There's a lot more resources, I think, that go into a study where you're actually going to be changing the way patients are cared for, especially if the intervention you're studying is like something that's kind of new or investigational. I just think that there's a high burden to like make sure you're monitoring things very closely. So then the resources, I think, really start to go up when you start to get into the randomized trials. But all that said, people pull these things off with like, smaller amounts of resources too. So I don't think it's impossible to do these higher level studies without any funding, but it gets a lot harder, and you just have to, make sure that you're keeping patients safe, to kind of that last part of the talk at the end there. I know, did that answer that question?
Oh, yes, definitely. One more thing. How many people, generally speaking, would you need to do a prospective study? Not sample-wise, but on the clinician side.
How many personnel to run a study are?
Yeah, exactly.
Yeah, it really depends on, really good question. I think it depends on the, it's hard to say an absolute rule because there's so many variables. Like how many patients are you enrolling? At what rate are you enrolling? How much data is getting collected? But even one like part-time coordinator can do a lot. So I think that obviously you need like, the investigator team who's really more ideally responsible for the overall design of the study and overseeing the implementation of the study. And then you need the somebody who's going to be the primarily responsible for the enrollment and data collection piece of it, which I think is at least like, one person. I work a lot with partners in Tanzania. That's why that Tanzania example came up. And there we have 3 research coordinators, but they do, a really high volume of enrollment of like open tibia fractures and stuff. And then we have, multiple investigators, both that kind of help oversee the study. And so as you get into more complex studies, then it requires a bigger team. That's a good answer now, but I'll tell you, one research coordinator can go a long way and really, expand your capacity to gather data and conduct a study. So start from there, and then you can kind of build over time, because one good study kind of helps you get funding for the next study and so on and so forth. You can sort of build that capacity and build that infrastructure over time, and you can kind of move up that pyramid as you have one success kind of tends to feed for the next funding and the next, next project that's maybe a little bit more complex. But you have to start somewhere.
Okay.
And then your question was about if you have a good research question, but you're not going to be able to do the sample size, should you still do the study? I mean, a nice option sometimes in that scenario is to think about doing like a pilot study or something like that. Just, show that you can do the study and work out some of the methods that you want to use, and then that becomes something that you can use to apply for funding or to get other, or potentially present it and recruit other centers to get involved or something like that. But in general, you don't want to start a study knowing with absolute certainty. You want to have a plan for how you're actually going to do the full study that's going to answer it. And so it makes sense to do a pilot study if you really have a game plan for how you're ultimately going to do that bigger study, whether it's getting more centers or recruiting more patients in some way. But I don't think you want to do, if you just clearly don't have the volume at your center to do that research question, then you probably want to, it's probably not worth like exposing the patients to the risk and putting in all those resources into it to try to do that. Now, another option too, though, is there are sometimes ways of maybe you can't look at, that reoperation outcome, those binary outcomes are like really difficult because they tend to require more sample size, but sometimes you can modify your outcome in some way, like in looking at, the RUS score, some continuous outcome measure of healing or something, and suddenly the sample size calculation becomes more feasible. So then maybe you're able to address your question a little, obviously the ideal is the outcome that matters most to patients, but sometimes if you really feel strongly about that question is important, by kind of tweaking your outcome a little bit to something more continuous that's more likely to show a difference, be less muddied by some of those other, patient factors, maybe you'll have an easier time performing the study at your center. So that's another way to kind of deal with that issue.
Thank you.
Yeah, good, awesome questions.
Also, feel free to unmute and ask your question if anyone else has one. I just have a question too, Dr. Shearer, about generating your questions in clinical practice. Do you how do you go about that process of you talk a little bit about searching the literature, but kind of what does your methodology look like when you have an idea in the operating room or something like that about kind of trying to go through the process of figuring out whether it's going to be useful to ask, or like how do you search the literature?
Yeah, I mean, I pretty much go to PubMed and start putting in the search terms, and see what's out there. I mean, if you ideally would do like a formal systematic review before you embark on a really big project. I don't think that's feasible. So usually I just start with kind of a basic set of search terms, and it sometimes takes some time, but I just sit there and sift through what's out there, and start relatively broad with your search and just take the time. You want to make your search broad enough that you capture things, but not so broad that you have to sift through 10,000 papers, but if you can get it to where your search terms are giving you, 500 things, like that's something you can get through in an hour and see if there's anything out there, and get a better understanding of it. And then again, maybe there is something similar, but there are ways that an aspect of it that's unique, and it's an iterative process, I think.
Thank you.
I just had a question, Dr. Shearer, this is Ramiz from Dartmouth. We work with a lot of folks around the world who are interested in doing research. We appreciate talks like yours. For those who want to connect, maybe residents or attendings in Haiti would like to embark on a research project, but are just looking for either people to connect with for some research support or resources. It looks like the UCSF website is a good one. Do you know of good resources for residents and attendings to go to help develop a research project if they're in Haiti at the moment? Either networks of people where they're looking for perhaps a research collaborator, mentor, or even just websites that have good starting points.
Yeah, it's a really good question. I think on the first part of it, of like networks, the professional society meetings and things like that. I was just at the OTA meeting are I think a good place to make connections. You can always reach out to us at IGOT, and can help make connections. We have a group called COACT, which is sort of still developing, but it's basically this consortium of orthopedic academic traumatologists. So the idea is to create a group of like-minded, North American institutions that are trying to do this type of collaboration. And one of the really important things that COACT is trying to do is help match, potential partnerships together. And so that could be another avenue, or a professional group that's doing that. As far as resources that are out there for, learning about research, I think there's a lot of stuff out there, a lot of, online courses and various things, or there might be things through, your university that will provide training. AO has an AO research teachings that are really good. So I don't have like one go-to thing, but I think there's a lot of stuff out there now, which is nice.
Dr. Woolley, you have your hand up as well.
Yeah, well, thank you, Jefferson. Hey, I'm Dr. Shearer, good to see you again. I just wanted to echo on the research part, what Ramiz mentioned. The OTA actually has a program now with Dr. Morshed, and he probably can talk about it when he talks in a few minutes. Pairing mentors and mentees into research, so that's an option people could have. And there are other options, even reaching out to Sign, and Sign can pair you with some of the surgeons there who have experience on it through IGOT, etc. My question, I guess, I guess you would emphasize, how important do you think Also, two questions. The first question is, in your mind, how important is the pyramid of evidence in determining and changing your practice? Like, how does it practically doing that kind of research changes your practice? And the second question is, you talk about research in PubMed. When do you determine what's trash and what's not? Not going into the whole open access kind of discussion, but what's your algorithm for this determining what paper is, has merit into your research system?
Awesome. Yeah, thanks, Pierre. Great questions and great to see you again. I think the first question about the pyramid, it's a really good question. So it's hard because we're giving a research talk right now and I'm trying to promote like really high quality research, but I do think there is an argument that a lot of important changes that have happened in orthopedics didn't have any randomized trial associated with them. They were just really smart expert surgeons who kind of figured things out. I think the reality is that it's sort of this balance, is that you need people on the one end who are kind of pushing the cutting edge. And some of those ideas end up being, things that really change our practice. But there's a lot of like new ideas that come out that, never persist at all. And that's the role of the higher levels of evidence. And I think that, it's almost like this constant push-pull of new ideas, and then they have to kind of get tested at the higher levels of evidence to be validated and really, work their way into our established clinical practice. So, while one could argue, well, no level one evidence ever, like, they didn't come up with, Charnley didn't come up with the total hip with a randomized trial, or, you could come up with those examples. We do need these higher level studies still to, when uncertainty still exists about, whether we should be doing things or not. And it's an important part of weeding out a lot of those new ideas that actually might have taken us in a bad direction. Were caught by high quality clinical research and registries and all these type of things. So I think it's, they're both really important. But yeah, it's a good, it's kind of a good philosophical question almost about research. The second thing was about PubMed and knowing what is, how do I know what's good in PubMed? I think, you have like the quality of the study itself just by looking at it, based on this levels of evidence and critiquing the quality of the study. I think the journal itself, makes a big difference for me. I mean, the editorial screening process of JBJS it's pretty tough to get through that net, so most studies that land in JBJS are probably pretty darn good, and each of the specialty societies has like a journal that's, tends to be their premier journal, JOT for trauma, for example. And so, things that are in those journals tend to be higher quality. And then I think you have to also just, learn how to critique, critical. You have to learn the skill of critical appraisal of literature. You have to learn how to recognize the different sources of bias, and be able to sort of make the distinction between good and bad studies in too. So I think it's kind of a combination of those two things.
Thank you.
Yeah, thanks, Pierre.
Great. And in the interest of time, thank you, Dr. Shearer, for joining us today. Well, we're going to take a short break. So we'll be back in about 5 minutes. So about 1:16 p.m. to resume with Dr. Morshed's talks. But if you have other questions, please save them, and Dr. Morshed will be available to answer as well. But thank you for joining, Dr. Shearer.
No problem. Thanks, everyone. Wonderful to see you.